Okay, great. I think we must start. It's just after 5. We still have a lot of other people joining us. So welcome everyone. I'm Marti Vieja and I'll be one of the hosts together with Mignon for today's webinar. It's a very exciting webinar about blood gas analysis with Prof Argent. And then Dr. Susan Murphy will be talking about electrolyte abnormalities in children. So I'm going to ask Mignon to please introduce Prof Argent to us. So he'll start, and then second we'll have Dr. Murphy. Thank you so much, Mignon.
Great. So hi there, everybody. Really delighted to see so many people already on this webinar. We know that blood gases and electrolytes are always a little bit of a mind tickler, a brain tickler. And it gives me great pleasure to introduce Professor Andrew Argent, who I think has probably spent more time in his career looking at blood gases, and so he's absolutely the perfect person to be giving us this talk today. He has recently retired in person from the ICU at Red Cross Children's Hospital and the University of Cape Town, but still has an incredibly active mind, doing lots of behind-the-scenes research and support of people doing research. And Andrew, we really look forward to you giving us a talk on this tricky topic, and I know you're going to make it really easy to understand. So thank you very much.
Well, thanks very much, Mignon, and let me just see if I can get the slides up. I think that's a very kind introduction, and I'm hoping that people won't feel the need to apply an ice pack and a wet towel at the end of the session, but let's see how we go on that. So over the next half hour, so I'm just really going to be talking about some of the issues of acid-base relationships and some of the clinical approaches that actually relate to that. Let's see if we can get the slides to advance. There we go. I'll start out talking a little bit about acids in general, then talk about the carbonic acid system and how that relates to clinical practice. And then I'm going to talk a little bit about a different approach, which is Stewart's strong ion theory, and we'll finish up by going through some practical cases. So let's start up with some very basic stuff regarding acids. And Bronsted and Lowry many years ago defined an acid as any substance that can act as a proton donor, and an alkali as a substance that can act as a proton acceptor. And what we're talking about is that you can have an acid which can break up into a proton or a hydrogen ion and an anion. And we also know that that reaction follows a constant, so that you can derive this particular formula. It says the concentration of hydrogen ions plus the concentration of anions, or multiplied by the concentration and divided by the acid, will give you a constant. And if you turn that around, you come out saying that the concentration of hydrogen ions is given by a constant multiplied by the concentration of the acid over the anion. And if you then accept that pH is the negative log of that hydrogen ion concentration, you end up with this statement along there, which is actually, I'm going to call it equation 3, but it's one that we recognize. What we don't always recognize is that that equation holds in general for any acid. It holds specifically for phosphates and phosphoric acid. It holds for proteins. And I'm going to put right on the table right now that proteins are weak acids. So we need to keep that at the back of our minds. And then specifically for the carbonic acid cycle, which we'll talk about in more detail, we get that pH is a constant plus the log of the bicarb over the PCO2, or something along those grounds. So let's digress for a moment and talk about, so what are these concentrations? When we talk about hydrogen ion concentrations in water, just plain water, that does make up some 60 to 70% of our bodies, what is the concentration of hydrogen ion in water? And what you'll see in this particular equation is that in plain water, at a particular temperature, there's about 155 nanomoles per liter of hydrogen ions. Now, to put that in perspective, a thousandth of a millimole is a micromole, and a thousandth of a micromole is a nanomole. So we're talking about nanomoles, which are about a millionth of a millimole. So right up, if you're used to talking about bicarb in terms of millimoles per liter, and you're equating that rapidly with the hydrogen ion concentration, we're not in the right ballpark. But let's look at humans. So at body temperature, with a pH of 7.4, we have a hydrogen ion concentration of about 40 nanomoles per liter, or about 40 millionths of a millimole per liter. If we actually look at different parts of the body, what we find is that in gastric acid, you have as much as 150 milliequivalents per liter, and that gives you a pH of about 0.8. In plasma, with extreme acidosis, you're talking of a pH of 7, that's pretty severe, and you're talking about 0.301 milliequivalents per liter of hydrogen ions present. Normally, as I said, about 40 nanomoles per liter, and in extreme alkalosis down to 20 nanomoles per liter. And when you concentrate your urine up to maximum acidity, we're talking here about 0.03 milliequivalents per liter and a pH of 4.5. So that's just highlighted something. We're talking about general rules about acids. We're talking about hydrogen ion concentrations that are in the nanomolar range. And we're talking about equations that hold in all situations. So let's focus a bit on the carbonic acid. I mean, carbonic acid, we've got CO2 and water combining, particularly if there's carbonic anhydrase present, to form carbonic acid, which can then separate out to hydrogen ions and bicarb ions. Again, if we go back to that equation, you can apply that to this piece of that thing, which says the hydrogen ion is related to the ratio between the carbonic acid and the bicarb, or you can put it that the hydrogen ion is a constant times the CO2 concentration divided by the bicarb, which is the Henderson equation. And we know that you can calculate the concentration of CO2 in any solution by multiplying the pressure of CO2 by the solubility coefficient for CO2, which is 0.0307. And that gives us the Henderson equation, which you see below there. And that brings us back to the well-known Henderson-Hasselbalch equation, where pH is a constant times the log of the ratio of the bicarbonate to the concentration of CO2 in the serum. And we know that in most situations, the pK is about 6.1. I just want to highlight a couple of things there. First of all, you can't change bicarbonate independently, because the moment you change the bicarb, the CO2 changes. And so what determines the pH is not the specific concentration of bicarb or the PCO2, but the ongoing relationship between those all the way. And again, to highlight for you that in the body, bicarb is measured in millimoles per liter, and the hydrogen ions are measured in nanomoles per liter. So when we do blood gas analysis, the blood gas analyzer will measure for us the pH, the PCO2, and the PO2. If you know those, you can use this equation here to calculate what the bicarb is. And so that's the bicarb that's being calculated. But a bicarb on its own is quite difficult to interpret because, as I said, the issue is the ratio to the PaCO2 rather than just the bicarb. And so one of the ways of dealing with that is to say, let's calculate the standard bicarb, which means what the bicarb of the specimen would have been if the PCO2 was 40 millimeters of mercury at 38 degrees centigrade. And so there are a number of curves that will calculate that for us. And that's what the standard bicarb is. So in a sense, what you've done is you've taken abnormalities of CO2 out of the system, and that helps you to say, is the CO2 up or down, and is the bicarb up or down? And then the base excess or base deficit are simply calculated from what it should be and what the standard bicarb actually is. And that helps us to say, is there a metabolic acidosis or metabolic alkalosis? And so if you look at what happens in the body, you've got a metabolic component, which will produce a lot of the factors that relate to the bicarb, and we'll come back to that. And you've got a respiratory component, which relates largely to the CO2. And for instance, if you're in respiratory failure, what's going to happen is that you'll primarily have failure to blow off CO2. CO2 will go up. Because the denominator is actually getting larger, this number will get smaller, and so your pH will get less. Of course, while that's happening, the bicarb will change, and the body will have some compensatory mechanisms to try and bring the bicarb back into range. But it is worthwhile pointing out that the body won't overcompensate. So if you've got a metabolic acidosis, a respiratory acidosis, the body won't compensate more than at maximum to 7.3. It doesn't see the point of doing the extra work, and that's about the range. So if you end up with a pH in the presence of a very high CO2 that is above 7.3, you've probably got an additional metabolic component going on. Likewise, if for some reason the body chooses to blow off lots of CO2, either because the ventilator is set too high or because the patient is actually hyperventilating for one reason or another, what's going to happen is this denominator will actually get substantially lower. That will mean that the overall number will get less. And so actually what you'll start to do is to get the alkalosis, and the compensation will tend to reverse that. So far so good. And I think many of us are accustomed to dealing with those sort of things on a day-to-day basis. And it makes sense in many ways to focus on the carbonic acid system because so much depends on breathing. The kidneys do generate bicarb. But there's a problem, and that is that there are other acid systems in the body. So you've got the phosphate system, you've got the protein system, and of those, albumin is probably the most important. But if you get into metabolic conditions, there can be all sorts of other acids around, including ketones, phosphates in renal failure, and then toxic products, either from poisoning or from inborn errors of metabolism. And so we can't just focus on the carbonic acid system, and it doesn't really help us to understand everything. And so what you see is that while the lungs look after CO2, the kidneys can produce bicarb and hydrogen ions, but also ammonium. In the liver, you may be producing ammonium. You've got a whole set of non-carbonate buffers, including hemoglobin, proteins, phosphates, etc. And they're different things coming from dietary intake and metabolism. And that's where Stewart's strong ion theory came in. And back in about 1981, Peter Stewart, and here's a photograph of him. Some people who've struggled to imagine his theory possibly wouldn't imagine him being such a friendly and kind sort of guy. But back in about 1981, he came up with this strong iron theory. And the underlying rule is that in humans, the pH is determined by only 3 independent variables. That's PCO2, the strong iron difference, which is the charge difference between chloride, the strong anions, and the strong cations, sodium. And we'll look at that in a little more detail in a moment. And the total concentration of all the non-volatile weak acids, including phosphates and proteins, and maybe some others there. And all other variables are dependent, not independent variables. Underlying that is that at all times, the total body must maintain electrical neutrality. The dissociation equilibria for all the incompletely dissociated substances, including water and all the acids, must be all satisfied, and you've got to have conservation of mass. So let's look at what these strong ions are. I mean, the strong ions here we're talking about are primarily sodium and chloride. I mean, sodium is measured in the 140 millimoles, where things like potassium, somewhere around 4, calcium, somewhere around 1 to 2, magnesium, 1 to 2, are tiny numbers in comparison to the sodium. On the negative side, chloride sitting at probably 115 or thereabouts normally, and bicarb somewhere sitting around 24 or that range, are massively higher than most of these other things. The only consistently significant weak acid that's around in our body is albumin. And what you can see is that at all times, the positive charges and the negative charges have to be balanced. And as all these things change, the chloride, the lactate, the weak acids, the phosphates, and the albumin, the bicarb is actually a dependent variable and can vary in response to that. So what you can then get is this, you can have the strong iron difference, which is the difference between the sodium and the chloride, and it's made up largely of this whole group that I've colored there. What we can see is that the strong iron difference is the positive ions minus the negative ions. So if I put those, that's what it looks like. The negative ions are in blue, the positives are all in positive. And you know what? The potassium, calcium, and magnesium are usually pretty small numbers, and they don't vary a whole lot. So basically, I can bring the strong iron difference down to sodium minus the chloride and the lactate. And in the normal situation, the lactate is pretty low. If you look at it another way, the total weak acids will be made up of albumin, phosphate, and then the other weak acids. And actually, I could calculate the bicarb by saying the strong iron difference minus the weak acids, because the strong iron difference is that whole area, and all these are the weak acids, which gives me down to these equations. If I come back to the Henderson-Hasselbalch, we've got pH equals pK with the and log of the ratio of the bicarb and the PCO2 and the CO2. But I can also express bicarb in terms of the strong iron gap minus the weak acids. And what that means is, if I start looking at that equation, anything that increases this number above here will actually increase the pH. What that means is if the sodium increases relative to the chloride, or the chloride decreases relative to the sodium, that will increase the pH. If these, like the albumin and the phosphate weak acids, get less, that will actually increase the pH. So that's some of the maths behind it. But what I'm saying is that if you increase the chloride ion relative to sodium, you will produce an acidosis, which has got nothing to do with PCO2, nothing to do with bicarb except indirectly, and is entirely related to the ratio between sodium and chloride. Any increase in weak acids like lactic acidosis, ketoacidosis, poisons such as any of those, renal failure, organic acidemia, will create a metabolic acidosis. And interestingly, raised albumin or raising other proteins, which are relatively rare, will create a metabolic acidosis. One of the ways you can check for that is looking at the ratio between chloride and sodium. If the ratio between chloride and sodium is greater than 0.75, or you can do it by correction factor, that means you've got a hyperchloremic metabolic acidosis. If you lose sodium relative to chloride, what that's going to do is create metabolic acidosis. And if you give sodium chloride with a ratio of sodium chloride is 1:1, what that'll do is effectively create a metabolic acidosis. On the other hand, if I decrease the chloride relative to the sodium, I will create a hypochloremic alkalosis. And it's interesting that a fall in albumin also creates a metabolic alkalosis. And that's important because in many situations in the critical care environment, albumins may fall sometimes precipitously. And what that may mean is that if the albumin's very low, there may be a metabolic acidosis present, which is hidden by that albumin level. And again, taking you through some of the causes of hypochloremic metabolic alkalosis and chloride loss, leverage to sodium, vomiting, and probably one of the most common that we see with diuretic therapy. So just to highlight what I've said is that the problem with standard carbonic acid-based analysis is that we may miss all sorts of abnormalities, particularly if we have big changes in albumin, phosphate, particularly in renal failure, if there are abnormal anions present, as in many of the metabolic acidosis or poisonings, and if we start giving significant volumes of fluids, particularly fluids that have a high sodium to chloride ratio. What is interesting is that you can go back to that base excess and you can calculate the change in base excess due to the sodium and chloride relationship, due to lactate present, due to albumin, and due to any other acids. And I'm just going to take you through a couple of examples on here. So here we have a patient who's post-surgery, and they've just given this patient a whole volume of 0.9% saline. When they do a blood gas, what you've got here is a pH of 7.28, so he's clearly acidotic. The PCO2 is relatively low, so that's not the cause of the acidosis. And the bicarb is low, and the base excess is high, or is high negative, or there's a base deficit. So we're happy that this patient has got a metabolic acidosis. Now we've got some other numbers here. We've got a lactate, which doesn't look very high. You can see the glucose, the sodium, potassium, and the chloride. If we do the calculations, what we can see is that the part of the acidosis that is due to the relative hyperchloremia is about -11. You can see that there's really no contribution from the lactate. And you can also see that the albumin, which is very low there, it's 28 as opposed to the normal 48, is actually offsetting it and hiding some of that level of acidosis. And there's really no other acids that are around. So this patient has got a metabolic acidosis, which is almost entirely produced as a result of hyperchloremia. Here's another example. Here's a patient who just arrived in the emergency department with abdominal pain. And when they did a gas, this patient has got a profound acidosis, a pH of 6.8 or thereabouts. Again, you can see what's happened to the hydrogen ion concentration. This patient's hyperventilating as best they can. So what you've got is a profound metabolic acidosis with a base excess of -35. You've got a lactate, which isn't particularly high, and the patient's saturating well. And let's actually look through the numbers. The sodium is relatively low, but so is the chloride. And if you look here, the proportion of this patient's acidosis that relates to the hyperchloremia is about -17 out of that -35. Lactate's not contributing, albumin's not making any difference, and there's another whole set of extra acids, which in this case are the keto acids, and I'll show you that this patient has a glucose of 35. So here's a patient with diabetic ketoacidosis, and it's interesting to see that in this patient, there's a huge amount of acidosis from ketones, but there's a large chunk of acidosis, which is there as a result of the hyperchloremia. And this may be really useful if you're trying to work out how best to treat this patient. And you can see why giving a balanced salt solution rather than just so-called normal saline, or saline, which has 1-to-1 concentration of sodium and chloride, both at 150 milliequivalents per liter, may not be appropriate. Here's another patient arriving in the ICU, pH of 6.83. And you can see here that this patient maybe isn't making as much effort as we'd like. That CO2 should have been blown lower under that context. And the base excess here is -22. Again, a profound metabolic acidosis that isn't being adequately compensated in any way by the CO2. You look here, the lactate is 15, and that may be contributed to because the SATs are only 80. And if you look down here through the numbers, you can see the sodium and chloride. Well, actually, that's almost offsetting it. You've got a measure of hypochloremic metabolic alkalosis here. You've got a profound metabolic acidosis with a lactic acidosis. Your very low albumin here is hiding some of the profound metabolic acidosis. And you've got a whole lot of weak acids, probably related to liver dysfunction and some of the other products of sepsis. So what I've tried to do is give you some overview how, while carbonic acid analysis and what we use on our CO2 and pH is useful, it's sometimes inadequate. The strong iron theory, which is no longer quite that new, given that it was produced some 40 years ago, may help us to provide better insight into the effect of other electrolytes and other causes as to why this patient is acidotic. And that has major implications as to how we might think about treating them. It does mean that if you thought that you could treat an acidosis by giving a bolus of albumin, that's not true, because albumin is a weak acid that's made up in a solution of sodium and chloride with about 150 millimoles per liter of each. So that's not going to do things unless the patient is profoundly hypovolemic. And I think it gives me a good opening to hand over to Sue to start talking about the major electrolytes as we look at critically ill patients. So thank you. I hope some of that makes sense. I'd be happy to answer or try to answer some questions, and maybe we could do that after Susan's presentation. Thanks a lot.
Thank you very much, Andrew. That was really amazing. I think everybody should have that lecture before they enter medical school at any rate, because if we had that early on, we'd all do a lot better. Andrew, I just want to ask you a question at this point. A lot of units do not have lactate on their blood gas analyzers. And just from my experience, I've found it a very useful modality. Do you want to just comment on that?
So, look, I agree that it's very useful to have some measure of the lactate. But what's useful is that if you start looking at the causes of your acidosis, and you, for instance, look and you see, can I explain this adequately on the basis of hyperchloremia? If this patient is not hyperchloremic and there's a big anion gap or a big strong ion gap, what it's telling me is that there have to be other acids which may include lactic acid somewhere in that mix. And that then means I need to say, okay, let me actually ask people to measure it or look for it. So I think, what's useful is to understand how, the hyperchloremia particularly may contribute to acidosis. But that sense of where the gaps and the anion gaps come from make you look for other things, be that lactic acid, pyroglutamic acid, methylmalonic acid, or whatever those are. It gives you a clue that you need to look. I don't know if that answers what you're asking there.
Absolutely. Any other questions at this point? I can't see anything in the chat. So I think let's just go on. Andrew, thank you for offering to hang around until the end. And I'm